So good afternoon. It is 12:35, and it's my understanding that it's time for us to get started. I'm Gail Johnson, and I am the co-vice chair of the African American Health Network of Dane County. Let me tell you a little bit about the African American Health Network before we get started. The African American Health Network was started in 2003. And we are a small organization. We're not a Fortune 500 or anything like that. We are a small organization, but we are a small, committed organization. We are committed to the health and well-being of the African American community in Dane County. And so we do what we do because it's part of us and because we feel that it's important. So part of what we're going to talk about today, health history and representation matters. That title is actually taken from one of the programs that we had through our African American Health Network activities. And I should tell you that in 2003, one of the reasons that the network became an organization is because at that particular time, Denise Carty, and she is now Dr. Denise Carty with CDC. Denise Carty was the minority health officer with the Wisconsin Department of Health Services. And Denise and I worked together for years, and we just kind of, would have different conversations about what was going on in the community, but we wanted to do more than just talk. We wanted to do something. And so one of the things that I always tell people is that we all learn from education and awareness. And so we obviously wanted to put our arms around the community, but we also wanted to learn what were the things that even those of us who are in the healthcare arena, what is it that we're missing? So that's where health history and representation matters came from. Okay, yeah, that's not us, so.
Can we get the technical staff?
Otherwise, I could just keep going.
Okay. Go ahead, 'cause we don't have.
Okay. So I know that the technical issues will be worked out in a minute. But when we talk about health history and representation matters, when we look at health outcomes, and we hear a lot about health disparities these days, and unfortunately, with so many health conditions, we hear that African Americans, whether we're here in Dane County, statewide, Wisconsin, or nationally, we are severely impacted when we start looking at heart disease, cancer, stroke, diabetes. Those are among the leading causes of death. And when you get folks from the Black community to talking, you'll hear, I have diabetes, or as some people say, I have sugar. This morning I was part of a breast cancer meeting where we talked about some of the things that are going on with African American, breast cancer survivors and thrivers. So we know that when we start talking about health, we have a long way to go, and that's one of the reasons why we're here today. In terms of our history, when we look at the fact that we, as Black folks of African descent, we've been here since at least 1619. Some folks say that there were some of our ancestors who came with Columbus in 1492. So somewhere between 1492 and 1619, we know we started arriving here. We didn't come here because we had nothing else to do. We were enslaved. And one of the things to keep in mind is that being enslaved, that meant we were working. That meant that our Africans who were enslaved were working the cotton fields in Mississippi, the rice plantations in South Carolina, the tobacco fields in Virginia, and so on and so forth. Here's where the health comes in. Yes, we were working. And so if we're working, that means we've got to be healthy enough to work, healthy enough to work in the fields, healthy enough to work in the homes. So it's no wonder that today, when we start talking about the impact of health and well-being on the African American community or the Black community, there are some things that we need to keep in mind. One of the things that I always think about, because part of what I do is I work on cervical cancer screening and prevention when I'm not with the African American Health Network, thinking about Henrietta Lacks, thinking about the fact that Henrietta Lacks was born in Virginia, and as I pointed out, she, being from Virginia, one of the things that she and her family were responsible for, even though she was born in 1920, they worked the fields, the tobacco fields in Virginia. Well, many of you know that Henrietta Lacks, the immortal life of Henrietta Lacks, was diagnosed with cervical cancer in 1951. However, she didn't survive, but her cells did. And one of the things that was so interesting is that this day, if you go into a doctor's office or you go into a clinic or a hospital, you know, you will hear talk about HIPAA, you'll hear talk about confidentiality. You will be given forms to sign, read and sign if you go for a procedure. That wasn't the case with Henrietta Lacks. So what happened was this mother of 5 children, again, had cervical cancer, and she passed away from the cervical cancer. However, her cells lived on. And because of her HeLa cells, a lot of folks have benefited from the fact that, you know, she was, in fact, immortal. She's no longer here, but her cells are. And then, of course, we have the Tuskegee Challenge, or the Tuskegee Syphilis Project, where in 1932, Black men in Tuskegee, Alabama, were part of a syphilis study, and many of the men, as I understand it, a certain number of the men who were part of the study had syphilis, and a certain number of the men did not, probably somewhere half and half. I forget the details. When I go back and I look at, again, confidentiality, HIPAA, there was none of that. These men did not even know what they were really doing when they were participating in this study. This went on until the 1970s, and so you can imagine those men, those Black men who were not treated, died from the syphilis and probably from some other things. But in 1997, President Bill Clinton decided it was time to apologize for the Tuskegee syphilis study, okay? But the apology wasn't really enough. So there have been other, shall we say, things that went to the families. For instance, we know that the family members, after the men died, received medical care. We know that even the men, when they were signed up for the study, were offered, get this, a meal, health care, but they didn't really know what they were a part of at that particular time. So when you look at what happened with Henrietta Lacks, again, mother of 5, and you look at what happened with the Black men in Tuskegee, is there any wonder that there is mistrust in the community when it comes to research, when it comes to medical care? And let us not forget that the other issue is that not everyone has access to health care. But that's another story. We'll get to that. So when we look at Black adults, and we say Black adults have less positive views of medical scientists than Hispanic and white adults. And as you can see, we're looking at, when it comes to Black adults, we're looking at, they don't necessarily have a great deal of confidence in medical scientists, and they don't necessarily think that, you know, what scientists and researchers are doing is actually in the best interest of the community. They don't necessarily have positive views of research and medical scientists. And this is the part that's really unfortunate, when you don't necessarily have a positive view or a great relationship with your healthcare provider. What I always tell folks is you have to be a partner in your healthcare. I say, if you go to a healthcare provider and he or she doesn't listen to you, look for someone else. But again, you've got to have some access first. And so some of the things that we're looking at today, we've talked about some of the leading causes of death. We're going to take a look a little bit in a few minutes at mental health. But again, some of the things that we're seeing today are a direct result of segregation, okay? And even today, you have areas of major cities, you have areas of the country where, you know, segregation, even though it's not necessarily the rule, it is in fact what's going on. And so again, you're in a community and, you know, someone comes in and says, I want to help you. That's not necessarily what folks believe. So, as I say, as I tell folks all the time, we all benefit from awareness, education, and research. And so today with my colleagues, we're going to talk a little bit about some of the things that we've done in the community. And hopefully you will learn something that you maybe didn't know before you came in today. So first, I'm going to ask Dr. Earlise Ward to come forward. And I always tell people that I knew Dr. Ward before she was Dr. Ward. Now, I want you all to understand, we were 12 and 13 years old at the time, right?
That's right.
That's
We
it.
were.
That's the story we tell. Dr. Earlise Ward is a UW Family Medicine and Community Health professor, and she leads the Cancer Health Disparities Initiative right here at UW, at the UW Carbone Cancer Center. Her research is focused on beliefs about mental illness and the development of culturally appropriate and effective mental health interventions for African Americans. Her current work is focused on further testing a culturally adapted mental health program delivered in church or faith-based settings by licensed mental health clinicians and trained pastors. And again, yes, we've talked just a little bit about the leading causes of death, and they've all been, you know, part of our physical health. But now we're going to hear from Dr. Ward, and she's going to tell you about some of the things that are important when it comes to dealing with our mental health.
Thank you, Ms. Gail, for that background and a bit of a history there. So thank you. So I will get started. This is a little different in that I don't have my slides in front of me, so I may be turning to look at the monitor from time to time. I'm not ignoring you. I'm just trying to get the content right here. So I will start out with why depression. Let me give you some ideas about why depression. So nationwide, 1 in 6 Americans report having depression within the past 12 months, okay? In addition, in any given year, 18 million Americans suffer from depression. And by 2020, which was 2 years ago, right, depression became the leading cause of disability globally. I just need one person to tell me what they think may have led to some of that. Shout it out. Let's do it. Let's have a shout out. There you go. There you go. So let's look specifically at African Americans, right? So African Americans or blacks, so I'm using the term interchangeably here, are 20% more likely to experience serious mental health problems than the general population, okay? In addition, African Americans are also more likely to report having severe depression and disability associated with the depression. And then receiving less care, and the less care has to do with lack of access to care, and for those who have tried to seek care, often receive culturally incompetent care. So that not seeking services or the low level of seeking service is multifactorial, right? We don't want to just blame folks and say, well, you know, they just don't have access to care. There's also the piece about the quality of the care that is being provided or not. So my research goals. I am particularly interested in improving the quality of mental health care and increasing outcomes for African American adults with major depressive disorder, as well as individuals who have cancer. And so with that, to achieve that goal, I've spent most of my career focusing on developing, testing, and implementing culturally adapted depression interventions for that population, and I'll give you a little bit more on that. And in my work at the Cancer Center, what we're learning is that we don't have enough participation from African Americans in cancer clinical trials, and so we're really trying to focus on increasing the numbers there, as well as increasing the numbers in our depression research. So just a short story to share with you kind of how I came to this work. Yes, the data is important, but I also believe in stories. And so I will share with you one story that led to my passion and commitment to doing this work. Years ago, while Gail and I were still in college together, on my way to my clinical site, I met an African-American woman on the bus. And so I call the story The Woman on the Bus. And we started chatting with each other. And she said, so what are you studying? And I said, well, I'm getting my PhD in psychology. And she said, what specifically are you interested in? And I said, I'm interested in cultural issues and counseling. And she said, oh, girl, and I think if she was standing, it would be like, oh, girl, let me tell you what happened to me. So she launched into telling me that she's had mood swings, and part of the mood swings is related to how cold it is in Madison and being black and living in a majority white society. So she said with the mood swings from time to time, it got in the way of her relationships, it got in the way of carrying out work-related responsibilities, and she started thinking about possibly getting some professional help. So she went to talk with her primary care doctor, and you know, the process is then you get a referral to specialty mental health care. So she did get a referral, but decided, I don't think I want to do that. You know, how us black folks think about mental illness, it means people are going to think that she's crazy. So she decided not to go, but things started getting worse, and she eventually did go. And she said to me, within the first 30 minutes, the counselor said to her, you know, you need to see a psychiatrist who would then recommend medication for you because that's what you need. And she said, what's wrong with that damn counselor? I went there to get someone to talk to and to listen to my story. And right away, he started telling me about medication. She says, well, you know what? I never went back to see his, you know what. So I always like to share that story because it really speaks to my passion and commitment for this work. When I heard that woman's story, I became really sad and started thinking, we need to do something about this. Somebody needs to do something about this. And in the recognizing that somebody needs to do something about this, I then realized, well, maybe I should be somebody who should be doing something about this. So here we are. My dissertation research, not to go too much into the past, but based on that woman's story, I then did a qualitative study to better understand African Americans' experience in counseling, because I heard on the bus a story of one. So I continued with my dissertation research, and believe it or not, I heard a lot of similarity in those stories. And so finished up my dissertation, then moved into then trying to better understand mental illness from the perspective of African Americans. Because again, that woman told me that she didn't want anybody to think she was crazy. Not that she had a mental illness, but don't want anyone to think I'm crazy. And as we did some of the other studies, we were learning the same. So I launched into learning more about their beliefs. In the interest of time, I won't go into any details about the findings, but we looked at beliefs among African American women, found that there were issues of stigma, there were concerns about availability of services, concerns about not receiving culturally competent care. They were very apprehensive about medication because taking medication meant that you are, what's the word? Starts with a C. Crazy, exactly. But they did express openness to talk therapy, to counseling, and they wanted counseling in a group context. Do you know why? So that this way I'm not the only one who's crazy, right? So again, recognizing all of those issues, we then replicated that study with African American men, because when we started with African American women, African American men would say, well, what about us? You know, we're kind of crazy too. So we then replicated the study and included African American men, and the results were very much the same. So with that, we then recognized that we needed to develop more culturally adapted depression intervention. So I took what I learned from them and we developed the Oh Happy Day intervention. So 12 weeks of group counseling with a booster at week 13. I won't go into all of the details with you, but from some of the things that we learned, if you can see week 2, we focused on cause, risk factors, signs, and treatment options. Again, we recognized that people didn't understand. They didn't quite have a good understanding or awareness of the symptoms to begin to then initiate treatment-seeking behaviors. We also recognized that as you'll see, week 4, depression and chronic physical health conditions, we saw high rates of diabetes, hypertension, and folks thought, well, yeah, I'll just work on my diabetes and hypertension, and they lost sight of the fact that you needed to do both, that the depression continues. Moving on, we ended our session week 12, you'll see graduation, and we did that because as we started piloting this work, what we were hearing from folks is that they didn't think of it as treatment or an intervention. What they thought of it as was class. They were coming to class. And so we thought, okay, if you come into class, when you finish up your class, you graduate and you get a certificate, right? So we build that piece in, and I share that with you, again, to share in doing our community-based participatory research, how we really engage with our participants as well as larger community stakeholders to better understand these issues from their perspective. So just a briefing on some of what we've done as we move forward with the Oh Happy Day class. I was then able to get a grant from ICTR focusing on stakeholder and patient engagement. And in that work with ICTR, what we did was we developed a faith-based community advisory board, and you will see the other members that I'm presenting with here are all members of that community advisory board. And then we worked on developing a faith-based depression intervention. And I will just show you a photo of that here. Oh Happy Day Faith. And we went with developing Oh Happy Day Faith because as we were piloting the traditional Oh Happy Day, we were hearing from folks about how they cope, that they use religious coping, that it's about praying and getting folks from the church to pray for them. And even as we were doing the traditional Oh Happy Day classes, people would ask, well, Dr. Ward, you know, Sister Jean is dealing with some stress. Can we pray for her? And I would have to tell them, this intervention is not a faith-based intervention. However, when we're done, you do have access to the room. You all can kind of use that space to do what you need to do. So again, in the interest of doing community-based work or community-led research, we then adapted the traditional Oh Happy Day and then worked with the faith-based community advisory board to then develop Oh Happy Day Faith. And so with that, I will transition back to Gail, but I will let you know my source of inspiration, quote from Dr. Martin Luther King, life's most persistent and urgent question is, what are you doing for others? And just take a moment, about 15 seconds, just to think about that. What are you doing for others? And I will now turn it over to Gail.
So if you want to take your seat at the Carla. So I am very, very honored to introduce Carla Peterson Gaines. In the community, everybody knows Carla. As a matter of fact, I remember telling someone years ago, I said, Carla is the community nurse.
Yes.
Okay, seriously,
Yes, ma'am.
all right? If she doesn't know it, if she doesn't have it, she's gonna work with you to help you get what you need, all right? So when Carla takes a break from being the community nurse, she is also the community research associate for the Community Academic Aging Research Network. She's a community liaison for Courts Insurance. And of course, she is my co-vice chair of the African American Health Network of Dane County. She brings the force of advocacy to work for equity in healthcare for some of our most vulnerable citizens, those receiving state Medicaid and Badger Care. She is a dedicated and tireless advocate and problem solver for clients. She's well known and respected for her outstanding work during the COVID-19 pandemic and in the Madison community at large. She has been exemplary in providing many health resources. See, that's what I'm saying, many health resources for marginalized people, as well as access to vaccination services during the pandemic by working in, get this, parks, schools, and other locations. And Carla, you and I did a drive-by. During the pandemic?
Yeah.
Did we do a drive-by?
Yeah,
Okay.
drive-by,
Okay.
yes, we
Yep,
did.
we did a drive-by. It was wonderful. Okay.
height
It was a little chilly, but we had a great time. Okay. She was a recipient of the 2021 UW-Madison Outstanding Woman of Color Award. Carla Gaines, take it away.
So good afternoon. I don't hope you, I'm on, oh, okay, they say I'm on. All right. So thank you all for really coming today and really being a part of this discussion. Nothing with us, for us, by us, with us. And we are just here today to really engage in a discussion of really the why. And so as Gail, I call her Dr. Gail because I've known her for a long time. Truly one of my inspirations in really involving in community work. And I dare not to mention, I know she is in the room, so I have to mention her. Shiva Badar, who you all just heard earlier. Wave your hand, Shiva. Another one of my key inspirationers back 30-some years ago when I started really engaging in community work. It was UCARE at that time, and Unity in Courts, and Courts now, and Lucretia Sullivan Wade. Wave, break your hand. We had a community, what we called Harambe, and all of community resources of what a family that was marginalized may need. It was a clinic, Head Start, parenting, dental. It was all of those things wrapped up in one. And when I began to look at how I could be a part of my community, that was one of the first spots I went to, Betty Banks and Hershey Barnett, who was one of the black graduates from the UW of Madison. So that's where I went, to the community, to the source. And as I continue to engage in community work and community partner with so many different health systems and faith-based organizations, and I'm a member of Delta Sigma Theta Sorority Incorporated and Divine Nine, who have service organization as a lifetime commitment. So as I began to do community work, and I've been with Courts now 30 years, with CARN now almost 3, that community work just began to merge together because, again, I want to be a part of uplifting my African American Black community, people that look like me. Because as a nurse at Northeast Clinic for over 10, 12 years, we as a community were always the first people on the list. HIV, diabetes, heart disease, mental health, everything. And I was like, I need to get my people off this list, right? And
Yes.
so as things begin to continue to materialize, and as I created the job that I have at Quartz to be a community outreach specialist and advocate, I went at that time to Vera Court, where Mother Horner, who huge community leader, and you're in the Black community, when you have an elder, you go to the elder first to get permission to be in that community, because she had built that community up. And so I went and asked her, I said, Mother Horner, is it okay for me to come into the community and to see what they may need and how I can be a resource or help to them as they are a help to me? And it's that type of communal back and forth is what I began to learn, because it's not what I want to do, it's what the community needs and the community wants to do. And it's very clear and important, you have to be engaged in that community work and engaged and plant yourself really in that community. And so as I continue to evolve, I've been with Courts now 29 years. This position came with CARN in research. And research is so critical to my community. We already saw Tuskegee and Henrietta Lacks, and we know those issues as being Black and being that we don't really trust the healthcare system, because this healthcare system was not built for us, right? It wasn't built by us, wasn't built for us. And so with that, I'm in the healthcare system, so I have to advocate for when I see things and systems that need to change so it can be for us and about us. And that's where that advocacy comes in at. It's where I may talk to a doctor and say, wait a minute, you may be speaking to her like she's 5. We're all grown in this room. Let's try to rephrase that. And I have no problem in talking to a provider like that because I go in there too with some knowledge of what's going on, some medical knowledge. So they kind of stop and say, oh, okay, let's try this again. Because again, the families that I work with, marginalized, those that are the poor, underserved, the most vulnerable in our community, they may not have that voice of advocacy to speak up for themselves because they're so used to someone looking lower, they're, down to them or in that type of space. And so, again, my job is want to lift them up, to say they are somebody, they have a voice, they should be concerned about their health. And how can we do that together? If you need help, let me help you do that together. So I'm raising up advocates and raising up my community to make sure that happens. And one more thing before we go to Dr. Wade. So when COVID hit, I'm a member of Mount Zion Baptist Church, and as Gail mentioned, it's the community nurse for everything. People call me, but that's good and that's okay. And so we were our church was one of the first churches that had in 2021 a Zoom. We had it on Zoom, but we did it in person, and we had all the health systems represented. Matter of fact, Sheba was there talking about the new vaccines that were coming out, right? And so, and we saw what happened with the vaccines that were coming out. We know folks that didn't look like me were all getting all the vaccines. And my community that was dying did not have access to that. So in our community, how do we make that change? In speaking with our health systems and speaking with our public health department, we said we want to have a injection site, a COVID testing site, an injection site right in the south side of our community. So our pastors with African American Council of Churches, where Pastor Wade is a member, and so those pastors got together to get that news out again so that information can come to our community. And it's not about, I will say that it's not always being fearful or scared. It's about education. So you want to give me a COVID shot, but tell me something about it. Tell me the why, right? Give me some education on the why. Let's have a conversation of my hesitancy, because I wouldn't say it's we don't want to do it. We want to die. We want COVID. That's not what we were saying. But what we're saying is, give me some education about it, and so I can make an informed decision. But make sure you are doing it in our community. Make sure you are tapping the Black and brown community, those that are those essential workers that can't work from home, those essential workers that have to be out. Though when you say social distancing, how does a family with 5 people in the household social distance when they all live together? So you have to change those types of language and that type of terminology and what it really means, and how really do we help our community make that happen. I'll stop there, Ms. Dr. Gail. I get excited.
So now that you have preached, we're going to bring a real minister.
Girl, preacher.
Okay. Reverend Anthony Wade is the pastor of Second Baptist Church right here in Madison. He is the vice president of the General Baptist State Convention. But here's what you also need to know. Pastor Wade was a program manager with the Centers for Disease Control and Prevention for 40 years. He is now retired. So, Pastor Wade, we're going to ask you to kind of get our discussion started. And we're going to ask you about what do you see as added value in incorporating the community and patient voices as community partners and advisors, not just participants in research or whatever's going on. Can you talk about that a little bit?
I would try, Ms. Gail. Good afternoon. Thank you very much. I'm the pastor of Second Baptist Church, and I had an outstanding career with the Centers for Disease Control. And one of the things I truly believe in the health field, we must take public health to the community. And how do you do that? Well, as the pastor of Second Baptist Church, yes, I believe in God. I also believe in individuals. In order to have a good Christian life, a good spiritual life, you must know about what's going on regarding your health. And I believe, and I have done it every Sunday, in our service, we take 5 minutes to discuss health concerns. It's very important. I have worked closely with Dr. Ward, and one Sunday, several of my members at Second Baptist Church, they were in the moment, in a spiritual moment. And I just looked at them. I said, are they really in a spiritual moment, or are they having other issues? And after church was over with, I asked the 2 individuals, may I speak with them privately? And they shared with me they were having some mental issues, some health concerns. So right there, I decided I'll get in touch with Dr. Ward. I will work with Dr. Ward, because we need to focus on the people, the community. So I'm very involved with the community. We just get ready to do a mental health COVID tomorrow with my fraternity. I believe in bringing health professionals into Second Baptist Church so they can address and share with us problems and health concerns focusing on African American and other population. To me, it's very important that those who are doing research, I hope I answered your question, Gail, those who are doing research in the community must have some type of respect for the community. Now, my career with Centers for Disease Control, I worked in Cleveland, Ohio, where I met my lovely wife. We celebrated 40 years this past Saturday. So I worked in Cleveland, I worked in Detroit, I worked in those major cities. And I was guilty going into the community, gathering the data, and not sharing the data once the data is completed. So I was totally guilty of that, not sharing the information. And so when I became a pastor, I said, this got to stop. We're going to have to work both ways because it's important for the community to do, for the researcher to do research in the community, but don't just prosper from you doing the research, you getting your doctorate degrees and PhDs, and then just leave the community.
Right.
Why not engage with the community and share the information that you gather? Or why not, with the grant, give the community some funding? Homelessness is important, you know. Violence is important, you know. So there's many ways that I think the community can work with researchers, and there's a need. And I truly believe once we get that dialogue together, everyone benefits.
Thank you, Pastor Wade.
And can I add on that to
Please,
Dr. Gail? I'll
please,
call her Dr. Gail.
please.
So this is where Karn comes in as we work with our older Black adults, and as I come in as a community research associate. So my job is to make those connections with the researcher. I'm in the middle, the researcher and the community partner. It's my job to make sure that they have that connection, that I'm helping them stay in connecting with the community partner. What does the community partner need? When the researcher needs a letter to send up to ICTR, send up to the NIH, you know, what is that budget requirement that Pastor Wade just said, and I call him Bishop. Pastor Wade just said, when you get done with your PhD, what sustainability are you going to have from my community? Okay, so you're doing a hypertension program. So after you see that Blacks are high in hypertension, as you figure out the reason why, you get done, you graduate from the university, and now you are at Harvard. And the Black community has still got hypertension. And where are you? Where's your information? Where's your data? Where's your partnership? Where is the budget that I should have helped her with to say, once your research is approved and done, what funding can we leave to the community in order to keep that work going? It doesn't stop. Once she gets her PhD, we have to continue the work. And Dr. Ward made a very good point in when she said, when you talk about community participatory research, she said they wanted some prayer. And she said, well, in this grant, really that's not a part, because the grant has certain criteria that's been approved that you have to follow. However, she said, that's what the community is saying we need. I need to go back, make some changes, put in what the community wants. Now we have, oh, happy day, faith, okay? Because that is that connection. Bishop said this is what we need to do. We need to make that happen, right, for the community. And I will be quiet, Dr. Gail.
And I will just add one more thing to that speaks to the importance of having those relationships and sustaining those relationships, because I was already in connection with Gail and Pastor Wade, Bishop Wade, So when those issues started coming up, I went to them and say, this is what I'm hearing. What do we do here? Versus not having any relationship with them at all and going in, it's like, well, who are you? What do
Right.
you want from us at this time, right?
Yep.
So we had those ongoing relationships, and I was able to come to them truly as a partner to say, I'm a professor at the university. I'm skilled in doing research. I'm also a licensed psychologist. I know mental health. I know mental illness. But I don't know enough about faith practices and beliefs to develop a faith-based depression intervention. This is where I need you. And can we come together in partnership? So it wasn't, Dr. Ward, the university researcher, it was all of us working together in partnership. So I just wanted to put that out there to say, keep that in mind, that we need to have sort of an even platform and really support each other and see the value in working with our community partners.
So a couple of things. First of all, Pastor Wade talked about his fraternity. Pastor Wade is a member of Omega Psi Phi, so just so you know. And one of the reasons that I'm bringing that up is because in talking about working with communities, we all know each other professionally and, and all of that good stuff. But the other thing is there are other entities in the community that we call on. Carla talked about the Divine Nine. That's the organization of black fraternities and sororities. This is a national organization. And so there are many times when we call on our black sororities and fraternities to help when we are doing things in the community. As a matter of fact, many times they will call on us to say, we're thinking about doing this kind of program in the community. Can you help? Okay, so keep that in mind. The other thing that, and how are we doing on time? I have no concept.
We have 10 minutes.
Okay, so one of the other things that we talk about a lot of times is, having folks that we can relate to when it comes to, accessing the healthcare system, when it comes to our mental health. I've heard the story about the woman on the bus so many times that when Dr. Ward doesn't tell it, I can tell it. That's how many times, but I love it. But here's what I'm getting at, and here's what I want our panelists to talk just a little bit about. I'm very, very big on working with students, okay? I mean, people will tell you, I love working with students. And I think that when we start looking at who's out there providing the care, and we look at what's going to be happening in 5, 10, 15, 20 years, we need more professionals from diverse communities providing the care. We need more Dr. Wards. We need more Pastor Wades. And we certainly need more Nurse Carlas. So I'm going to ask all of you to just talk a little bit about some of the work that you've done with students and how that has gone.
Oh, so I'm gonna answer that question. I thought Dr. Ward was gonna stand up. So I would say, with CARN and the CRAs, there are not many Dr. Wards on campus. So we get many students that I see in the room. We get professors. Right now we're working on a super ager project. The PI, he's black, but his students are both, they're both white. And so I'll give you this quick story because as we like to do stories. And I think it's okay that I've already talked to Sammy and Alex, and some of you all may know those researchers. But they want to engage in our community on some super aging and cognitive development and as it relates to Alzheimer's and dementia and amyloids, and I won't go deep into their research. But the first thing that we said to them is that, okay, so you want to bring this into our community. And this is the one thing that the African American Health Network does also. Because, you know, we call the university the Hill. We have so many researchers coming down to our community, to the Black and brown community, because in their research, they need to get some research on us, right? And so sometimes we have to screen that out on what's best for our community and what's not best for our community, and not to saturate our community with tons of researchers. So that's another key important piece of what we do as an African American Health Network. So with Sammy and Alex, I said to them, well, you know, the first thing you need to do is come and be involved in our community. You need to come to our events. I said, oh, we have an event Saturday. You need to come. Well, they were there. I said, you need to engage in Black businesses. You need to spend your dollars on some Black businesses. You need to be talking into the community. Let me introduce you to people in the community. And what we shared with Dr. O, we said to him, you need to hire some Black research assistants so they can be involved in this. And again, we should be pulling each other up and mentoring them, helping them navigate this system since we've been in it for a while. So that's what I would say, Dr. Gill, is that researchers definitely need to have them on payroll, that we need to be paid. You know, if you want to come to the African American Health Network, then we want to help you, but we're just not going to help you for free anymore. The free days are over. Enslavement, over.
Woo, okay.
I'll be quiet.
You got it, you got it. Pastor Wade, anything to add?
There's a great need for both parties to communicate and to really understand the community.
We have a few minutes for questions, so do we have questions from the audience?
Hello,
Hello.
how are you? My name is Bruce, and can I have two questions?
You
Be all
can
right,
ask a
Gail?
question, Bruce. Go ahead, Bruce. Bruce and I know each
know
other,
Bruce.
okay?
We
know
We know each other, okay?
Stay
Okay?
down. All right, first question is, I work frontline as a nurse, and I worked on policy and procedure for VA. And we created policy and procedure. I worked from November of last year until May of this year. And we created policy and procedure for the clinic service line, and some of it's being implemented in the hospital. One of the things, one of the first things was having an African American involved in hiring practice, because traditionally we didn't have any Black people when people sat down to be interviewed. And we created a bunch of different policies. I wrote scenarios of Black people's situations, of nurses and patients. And the white staff had the role model being those people and having those issues and talking about their feelings related to that. And then we worked on policies to change that and empower them and write happy endings. But my next thing is actually I'm working on nursing DEI. And being an LPN, which for me I'm joking, but it's low-paid nurse. And so, but it's a nurse no matter what.
That's right.
That's it.
Because
That's
we
it.
do everything we can and above our scope quite a bit of the time. But in writing policy for DEI for nursing, one of the things I've found is that other nurses, BSNs, MSNs, managers, things like that, they're what I call siloed. And I talk about before you write policy, you have to learn history of DEI, like Henrietta Lacks, and all of that, and the social, the economic, the community, the mental health parts of the history of African Americans, and why we don't do certain things, and why we don't fit, and why we don't want to come, and why and how we can read you and tell when you don't want to do care for us. And they look like we're not ready for this. We don't want to do this, but we want to write this policy. And I say that policy will be homogenized. It'll be whitewashed. It'll be ineffective. How can we get management or administration to actually want to leverage them and be committed for that? And the last one, I'll make this one shorter. Actually, I had this dream thing, and I was able to make it come true recently. I wanted to have a support system for black nurses, because I was a COVID nurse, and where I work, I'm the only black LPN in the hospital and the clinic, male. And it's been like that for 15 years, so I know what that's like a lot. And so we created this Black Nurses Support Group, and it's really new. It's called, pull up a chair, let's clear the air. And it's a place where we can come and talk about issues related to us and support us and say that we're awesome no matter what. And we've got LPNs, and we've got PhDs from UW. We've got nursing instructors from Madison College, and the goal is to grow that and to be able to support ourselves, and maybe next year possibly work with some of you ladies and gentlemen in community nursing because we do it anyway. You talked, all the things that you had talked about, we were already doing as individuals, but the goal is to support ourselves and learn to like ourselves enough so we can agree to disagree as a group and as a brother and sister group, and be able to coach people in our community so they're able to be the fishermen and the quarterbacks of their care. And so they can go in that room, and if that provider is not that right provider, then to fire that provider. Or if I'm a man and I'm a father, and my provider decides to talk around me and talk to my white wife, to fire that provider. And I work with veterans, and I tell veterans, you have to be the quarterback. Everybody else is a supporting cast. They're supposed to give you knowledge and give you wisdom and help you practically apply that and assess that. And when they score, we score. And so how can we get some of the things that we need?
Well, I think one thing, you've already probably answered your own question. One, I heard that, you are an innovator. You have to share your narrative, and that's what you did in regards to the hiring, the interviewing. They have to see somebody at the interview. You have to be intentional about who you're going to get on the panel and who you're going to have at the interview. It has to be intentional work to make that, because when you have the same thing, there is no diversity. There is no belonging. There is no inclusion. And so what you are doing is helping them see that piece of the narrative that they need to see. So if they want to talk about diversity and inclusion and belonging and equity, then you have to have that table of mix. It has to be that way. And you're starting that piece of innovation. And I don't know the exact, who exactly is doing. There is a Black Nurse Association coming up, so you know about that already, great. And your other comment was kind of how do you reach out to that diversity piece? I would just say, I'm gonna put my own friend out there, my sister friend out there, you probably know her too. I would email Shiva, her colleagues, and have a conversation. She just said that in the room the other day. Email me, let's go to coffee, have a conversation. And that's what I would do. She is right across the street. Take the bridge over to the VA from the UW, have a conversation. She's an amazing person to really kind of get that groundwork in. Have her come to the VA and give a talk. So yeah, and that's some of the things that I would just say, Dr. Bishop, just as a nurse, and engaging. Yeah. Okay, Dr. Ward, then come Vanna White.
Vanna Black.
Wait a minute. I'm sorry, Oprah.
Oprah.
Dr. Ward, you're gonna have to repeat that question because her mic's not on, and so make sure your mic is on when you answer, please. Nope. Try this one.
I turned it off.
You turned it off? Oh. There you go.
Okay, testing 1, 2, 3. So the question coming from the back of the room is about recognizing that some of the ways in which we do research and some of the policies that we have that inform and guide our research may not necessarily be as culturally sensitive or respectful as some of us would like for it to be. So how do we work with leadership to then begin to get those changes made so that we can do this work in more culturally respectful and sensitive ways? Did I get it? Excellent. So I will start out with what Carla mentioned before, connecting with Shiva, because again, leadership talk to leadership, and so you definitely want to start there. The other thing that I suggest is sort of grassroots. So as you're sort of thinking about what the challenges are, thinking about who you can connect with that can be an ally for you, okay? So allyship is really, really important. And as you get your sort of contingency, if you will, then with those numbers, then you begin to make your way up leadership, sharing with them, again, professionally, respectfully, what the concerns are, but also talking about the impact of the concern, sort of the bottom line. Because at the end of the day, the bottom line is what really matters. So as you talk with leadership and the folks that are making those decisions, if you can talk with them about how what you're seeing, these policies are then negatively impacting the bottom line, that's where you're possibly able to get some at least people listening and willing to make changes. The other thing that I also recommend, which is what I've done, is work with a community advocacy board like these folks here, who are, again, very knowledgeable about what's going on in the community, what our patients may be needing, so patient advocacy board, and then getting more input from those individuals to then take it, again, up to leadership with the folks that are making those policies to then say, here's what we're hearing. These are the people on the ground, if you will, in the trenches, and here are their concerns. So let's begin to sort of come together in ways to make the changes to the policies, the procedures, and then we will hopefully begin to see impact on the bottom line. Other questions?
We have a question, oh, I'm sorry. We do have a question online. Take this gentleman first.
No, please, if somebody's in line.
Oh,
Oh, no, on the line,
no, they're all,
Okay.
okay.
then we'll come back to you. You're next.
Okay. How do you work with nonprofit organizations in our community to ensure that they know what you are learning from participants in your research so that they can incorporate those needs in their programming?
That is an excellent question, and I'm thankful for that question. Are you all able to hear me with my mask on? Yes? Okay, thank you. I worry about my 78-year-old mother-in-law, so I keep my mask on at all times. So thank you for that. So, again, I do my work from the very beginning with my community partners. So I do community-led research where they're actively involved and they're taking leadership role in doing this work with me, so that as we're doing the research, they are able to make contributions to the research questions, thoughts about how we go about recruiting, who we recruit, and then thoughts on, once we're done with the work and we have the results, how do we disseminate the results? Yes, so we have to publish in these peer-reviewed journals, right? Because we do have that concept of publish or perish. So we do have to prioritize that. But we also need to take it back to our community partners so they can understand what we learn and then be able to make changes on their level, given what we've learned from the research. It's also important to celebrate what I've done with my community partners. I've done research with people with depression, okay? And again, people are concerned about confidentiality, but when we finished the depression study, I hosted a luncheon at the Edgewater Hotel. And I asked my research participants if they would be interested in joining and bring one person that they would like to share the experience with. And they all came to the Edgewater Hotel. We've done that several times. And it's our way, again, of giving them back the information. So the people who participate in the research, it's important for them to also have access to that information and really understand what you've done, but also show that you're valuing their contributions and recognize that when we do that, then we're increasing the research pipeline, right? Because they're more likely to participate when you ask them again. They're more likely to have positive things to say about the work that we've done and not be like what happened with Henrietta Lacks, right? So they're more open. So,
And also, Dr. Ward,
ahead.
putting them in the publication,
Indeed.
right? Putting that community partner, that Second Baptist Church in your in your publication when you put that publication out to all those big names.
Lucretia, you gotta, she's adding to it. That's not a question.
It's not a question, it's just a add-on. Just as Carla was saying, putting the community partner in the publication, but also being available if that community partner, because you start talking to them about research, they may have ideas that they want to pursue some type of grant, that you are available to be a part of their grant team as you've asked them to be a part of your grant team.
And Pastor Wade is a co-investigator on one of my NIH grants that is currently in review.
All right.
Thank you. My question is similar to the question that was asked earlier. I'm really fascinated by the faith-based intervention that was done with Oh Happy Day, not only because of how culturally responsive it was and like recognizing that this is what the community was asking for, but because of its innovation. I think it's so rare, at least for somebody who's a non-academic, to hear about cooperations between a faith-based community organization and any sort of, like quantitative research, right? And I wonder, Dr. Ward, like your colleagues of yours that are less, let's say, culturally fluent and connected to the community, was there any, in that experience of developing that, any like discomfort from your colleagues or pushback on that? Or in general, when you're a part of a primarily white institution like UW-Madison or anywhere else, that is not, maybe there's not a policy against it, but it's something that makes people, oh, this is new and scary and culturally unfamiliar to us. How can you get buy-in from the people who are in those positions of power and influence to say, even if it's something that's outside of the norm for our institution, we need to be culturally responsive in this way?
That is a great question. Thank you for that question. I will say that in the work that I have been doing through the years, I have not had any major pushback from the institution. Now, keep in mind that most of my career has been in the School of Nursing with the nurses, and there's truly a valuing of providing culturally competent services and really understanding our patients to provide patient-centered care. So I actually worked in an environment that supported that work, if you will. I've also worked with the community, so whenever, the few times there were any questions or concerns, then I would bring my community advisory board members in to have the conversation with leadership so that we could get buy-in. So that's how I've done it there. Now, with regards to NIH funding, this is like the third time that I've submitted the Oh Happy Day Faith intervention to get funded, and nothing yet. I've gotten, the reviews that I have gotten speak to the fact that they don't see the value in this type of work. And of course, there's separation of church and state, so that's where some of that is coming from. It is my third time. We will see kind of where we go with that, given the sort of the turning of the tide, if you will. Health disparities is in now. That's sort of the sexy research to do. So we'll see what happens this time. But where I am within the university, I've had great support for the work that I do. It's just at the sort of the federal level, I have not been as successful in getting the funding.
And also, I would say I'm a rebel and an advocate sometimes when you're an advocate, you have to be a rebel. And I would say, just like after Tuskegee and Henrietta Lacks, NIH had to change some of their criteria. They had to change some things on how they were doing research. And so I say we need to push the NIH to change some things to say that faith-based communities, because if you really want brown and black people, then faith-based organizations is a large target organizations. We pray, we go to church, we love the Lord. My daughter-in-law, who is a Latina, she go to Catholic church every Sunday. All my grandbabies is black. They go to the Holy Communion. So if NIH really wants to really shift, pivot, change the atmosphere, transform, work on health disparities, work on this gap, they've got to start with them.
Thank you, Sister Carla. As you can see, we could talk for the rest of the afternoon, but we are out of time. Let me thank all of you for joining us this afternoon. Stay safe, stay well.
Thank you.